common stool issues that we see mainly in the EBD. A lot of times you get questions about stool issues that a lot of times I don't know the answer to. So we're going to cover some campus ED diagnoses, but for the most part we'll talk about kind of a broad overview on what we should be thinking about when we see these complaints and what to do with different poop complaints. All right. So our first case, so we have an 38-week baby boy, now 10 weeks old, brought in for the first time by his parents for concern of lack of stool for the last 4 days. He's exclusively breastfed, and he's feeding well. He makes about 6 wet diarrhea a day. He's alert, he's active, his belly is soft, and he has no abnormalities in his rectal region. He's otherwise well appearing. And mom asks you, is it normal that my baby is not pumping? So newborn stool, so that's something I didn't know a lot about, and a lot of times we get questions about. So stool kind of changes as you go along, and this is totally normal for babies to, especially breastfed babies or formula-fed babies to breastfed babies rather than take this long, this early in life. So initially infants pass meconium, their first stool is in 24 to 48 hours. We don't usually see this stool passage in the ED, but a lot of times as an intern in the NICU or second year in the NICU, you might see this, and that's concerning for something like Hirschsprung's or more serious like anal abnormalities. This kind of changes as you go along with time and changes color and changes consistency. So this is a beautiful guide showing us our initial dark meconium, and it's totally normal for babies to change as they go along. You have things change as formula and breastfeeding changes and as children take in different kinds of food. So initially, stool can be dark green, brown, and then transition to a yellowish, seedier stool. That's totally normal. As this goes along, it's actually even normal for newborn babies to poop, or stool rather, every time they eat because we have something called a gastrocolic reflex. This changes as they go along, and it's even normal for stool to change color as kids take in more things to eat. So when is this something to be worried about? And actually with breastfed babies, as they get a little bit older, it's okay and normal for them to even go up to 4 to 5 days without passing a bowel movement, as long as their belly is soft and they look otherwise well. So when should we be worried? So we run into this a lot in EDs. Constipation, that's a really common case that we come across. Normally we think of it as less than 3 bowel movements a week in an older child. Any symptoms of fecal incontinence, fecal retention, or withholding behavior, or large, big stools that are really painful. So that's what we think of when we think of constipation, and what should we do about it? And what does it mean? So 95% of kids that present in the ED that we see really often present with just functional constipation, so no organic etiologies will be found. The most important things to look for are your history and your physical exam, and just really looking for signs of anything else. Most of the time you're not going to find anything else. Red flags that you should be looking for are things like bloody stools that could make you think of other etiologies, or bilious emesis that might make you think of like a midgut volvulus or some kind of obstructive pathology. Also failure to thrive, that you think about like malabsorption or any kind of ongoing constipation that might make you think about anal problems like anal stenosis and things like that. All right, so what do we do about it, and when do we treat it? So when kids come in with trouble passing a bowel movement, there's usually 3 phases, and we usually run into them in phase 1 and 2. So you want to disimpact them totally. It's not always in physical disimpaction, but with medicine or with a rectal enema, and then you want to keep that going. We usually don't see them in phase 3. So for us, the most important thing is how do we do this? So in infants or little babies, a lot of times you can just make dietary changes. Things we can recommend are things like diluting juices, or with like more sorbitol, avoiding cow's milk, and changing diet, increasing fiber intake when you're like 6 months old, pureed vegetables. We know this already. In kids who are impacted, when we find that in clinical exam, we have to go ahead and try to take that out, or else they're never going to be able to fully, or not never, but it's going to take a lot longer to fully resume a normal stool pattern. So we can use rectal or oral medications like glycerin suppositories, but that's not recommended for more than 2 to 5 days because of electrolyte disturbances. Then you want to continue and keep that going with either a change in diet or the use of stool softener. So we can treat it in ED, but most of the time constipation is totally functional constipation, and the most important thing is comfort and relief and good follow-up. So our next case is going to be talking about diarrhea. So we have a 3-year-old girl, previously healthy. She's brought in by her parents after 3 days of loose, watery stools. She has an older sister who's in school, who's also sick. So this is another common story. Her parents have been limiting her food intake, and she's been drinking lots of juice. She appears weak. She's arousable. She has chapped lips and good skin turgor and cap refill. She's slightly tacky to 135, but other vital signs are unremarkable. Okay, so diarrhea, what do we do about it? When are we concerned? What's our end goal? So pathophysiology, I'm not going to go into it in a lot of detail, but there's many things that can cause diarrhea, not just infection. So secretory diarrhea, dysenteric diarrhea is caused by an infectious agent that can often be bloody, cytotoxic diarrhea that can be caused by a viral agent or osmotic agents caused by things like malabsorption or reducing sugars in the intestine can often cause diarrhea. So many etiologies, to diarrhea. So what do we think about? So when we think about management, the most important thing for us to think about is hydration status. So in developed and developing countries, like the World Health Organization has recommendations for this, but for us, we're mostly going to practice in the developed world. So for our child, she's kind of moderately dehydrated, and we can look at her physical findings to kind of determine this. So her skin is kind of dry, she has chapped lips, she's mildly tachycardic, and all that falls into the moderate view. For moderate or mild dehydration, the main thing is oral rehydration solutions. Things that we can use in the ED or at home, or Pedialyte and Gatorade and things like that. But juice, soda is not really recommended and tend to make diarrhea even worse. When it comes to IV rehydration, so when do we consider it? In a child with severe dehydration, so signs of shock, vital sign abnormalities, or a child that really can't tolerate, oral rehydration. There is some debate on whether antiemetics should be used or Zofran should be given in kids with diarrhea. However, I think the overwhelming consensus of what I was reading was that if it can be helpful in a child where you want to orally rehydrate them, you can use that, and Zofran is proven safe and effective in children. When it comes to antibiotics, so that's something we think about giving. However, in our world, they're not really necessary. Most diarrheas are caused by self-limiting agents, and we don't necessarily need to give empiric antibiotics or test for stool studies. However, if you're in a different country or your child has recent travel, then that's something else to think about. If you are giving antibiotics, then the most important organism to cover for would be Shigella, so Cipro and Citro, and Ceftriaxone for severe infections. So long story short, rehydration is the most important thing, and looking at your child's clinical status and how dehydrated they are is how we're going to determine how we're going to rehydrate our child. Empiric antibiotics are not necessary, and most bouts of this are self-limiting. So, all right, we have our next case. We are in our first day of our NICU rotation. We have an X35-week baby boy, day of life 4, born normal vaginal delivery with peak pound, strictly formula-fed per mom. Initially he was feeding well, but now he's not really tolerating his feeds. His belly is distended, and he has a little bit of a residual in his OG feeds. The nurse calls you to bedside, you go to examine your patient, and then you get yelled at. You check the vital signs, and your baby is febrile, 101.4. With intermittent bradycardias and apneas, 90 to 180% DSATs, but self-resolving. The belly, when you finally get a chance, is distended, the baby's irritable, and you note some bloody stool in his diaper. Your senior's comfortably sleeping, so you go and wake him up. You hold feeds, you wake up your senior and your fellow, and you get your typical septic workup. You end up ordering a film, and you find this. So we have a couple arrows here. The white arrow, actually the black arrow I'm going to talk about first. That's pathognomonic for NEC. It's pneumatosis intestinalis, and that's gas inside the bowel wall. The other arrows you see are the white arrow right here, or up, right there, and that's going to be significant of portal venous gas. And the hollow white arrow is the soap bubble sign. It's basically when you have intraluminal gas and it looks super frothy, like a soap bubble. So those are all signs, especially the pneumatosis is a sign of NEC. So this is, bloody stool has many, like a broad differential, but in a neonate, this is definitely something that you don't want to miss, something that we can still see in the ED. We normally think of NEC as something that you see in preterm infants, and it is most common in preterm infants, but up to 10% can actually occur in term infants. And NEC can even be seen after 30 days of life. So it's possible to run into this in the ED. The thing to note is that most term babies that get NEC actually have pre-existing conditions. So if you have a PDA, treatment with indomethacin, or you're strictly formula fed, those are all risk factors for NEC. And that's mainly because of alterations in the biota of your intestines and the inflammatory cascade. So diagnosis is mainly based on your clinical findings and your x-ray. I'm not going to go into a lot of it, but basically you want to look for clinical signs of distension, apnea, bradycardia, and that should cause you to think about it, especially a preterm baby or a term baby presenting with these symptoms. Imaging, an abdominal x-ray. A lot of times, especially in the NICU, we treat it even if it's suspected. So even if you just see an ileus, you might treat it. However, if you see pneumatosis, that's pathognomonic. And also there is increasing use of ultrasound for this as well. Lab findings are not really necessary for diagnosis, but can be used for staging. So we might think about getting labs in a child that we see that we're concerned for this for. And how do we manage it? So there's different stages of NEC. Basically just varying from suspected all the way to advanced. And it really depends on how your child looks and how the x-ray looks and how lab findings are. And that's going to determine whether you go the medical or surgical route. You're only going to get a surgical consult, only go the surgical route if it's severe NEC. So if you have any signs of hypotension, acidosis, or you have pneumoperitoneum or any sign of perforation, that's when you get surgery involved. Otherwise, broad-spectrum antibiotics, NPO, and TPM if you're in the NICU. Aside from that, medical management. So we talked about NEC in neonates, but bloody stool has a really wide differential. So when we see a child with bloody stool presenting in ED, it's not necessarily just infections. So some of the most important things to think about in neonates, there's a ton of things that it can be, but malro or volvulus is important to think about and we'll learn about later. Basically, it presents with bilious emesis, and also bloody stool can be there as well, and a distended abdomen. That's probably one of the most common causes for obstruction or obstructive valve in a neonate or an infant. Bloody stool, so when you go a little bit older, that's when we start thinking about intussusception. So there can be many things like fissures, Meckel's diverticulum, Hirschsprung, but intussusception is one of those diagnoses that we commonly think about and don't necessarily want to miss. And we all know that you have your classic presentation of colicky, belly pain, right over quadrant mass, and bloody stool. You don't often see that. So if you do see bloody stool, it's something to think about. But if you see a child who's just lethargic and has not any other explanation or altered mental status, that's another thing to think about. As you get older, so even in young children, you can think about intussusception, and that becomes less common as we get older. In adolescents, the main thing that we want to think about is IBD flares or infectious diarrhea. Working a child up for bloody stool is really going to depend on your clinical suspicion for what's going on. If you see signs of distension, if you see signs of bilious emesis, anything like that, then you want to pursue imaging and getting a full workup. And it's also really important to do a rectal exam and check, especially in younger ages, for fissures or any kind of anal abnormalities. So just doing a good exam is probably the most important thing in determining where you go next. All right, these are just a bunch of pictures, mimickers of bloody stool. So a lot of times we have kids come in with red stool, and I've heard it before, that really you just want to get a history for, and it's not really bloody stool, it's just really tomatoes, or you have our fruit punch is another Any drink with red dye is another mimicker. Ceftonir is another antibiotic that's sometimes given that can cause red or bloody stool or that kind of presentation. And as I was warned by Dr. Shin one night in the corner deli Takis, the Takis that I was buying are definitely a huge mimicker of red stool and can cause bloody stool. False positives can actually occur by a lot of things, so red meat ingestion, even vegetables like broccoli, anything that contains peroxidase can mimic bloody stool. So we're going to talk about just a few other things regarding straight stool presentation. So we have a 6-month-old male, previously healthy, brought in by parents for frequent foul-smelling bowel movements for about 3 weeks. He's not gaining weight appropriately and appears tired, although he's responsive. You note a cough, and parents say this started about 1 week prior, and that's why they brought him in today. So malabsorption in this case, so this is definitely something we want to think about, and for this child, one thing we want to think about is maybe cystic fibrosis. Malabsorption can present in many different ways, but the main thing we hear is chronic or recurrent diarrhea. Stool characteristics can vary depending on what kind of malabsorption it is, which oftentimes we don't really find out. The main things we want to listen for are systemic symptoms of weakness, fatigue, and failure to thrive should clue you in that maybe there's something else going on. Other symptoms can include things like flatulence, bleeding, edema, tons of things depending on what it is exactly that's not absorbed. So we're not going to go into some detail, but there are different forms of malabsorption. So you definitely see hard malabsorption, and these things are usually watery stool going on for long periods of time. The most common is lactase deficiency or adult lactase deficiency that you can actually see as early as 2 years of age. You can see this in celiac disease, but that should clue you in. Fat malabsorption can also be seen kind of like in our child, like in things like cystic fibrosis that make kids prone to pancreatic insufficiency, and vitamin deficiency can also occur in this case. So protein and vitamin malabsorption can also occur. So again, not going to go into in too much detail. However, vitamin malabsorption is something to think about because when you have ADEC deficiency, the vitamin K deficiency can present in severe like hemorrhage and bleeding, which we don't often see, but it can occur. Protein losing malabsorptions can also be seen in a lot of kids with IBD or celiac disease, and that can result in chronic fecal loss of these things, which can cause failure to thrive and dehydration, muscle atrophy. All these should prove that there might be something else going on. So for us with malabsorption, in terms of workup, there's not a lot of times we don't necessarily work these things up in the ED. However, really determined by the child's nutritional and clinical status and any kind of coexisting symptoms. If the child is stable, a lot of times most of the time you could just have them follow up, but it's just important to be clued in on what could be going on. However, if the child is unstable, then we would pursue further workup. Acholic stool, so it's another thing that we can see. It's pale gray colored stool, and this is usually caused by loss of pigmentation from bilirubin, and when you see this, it's usually indicative of some kind of cholestatic pattern. This has a wide differential in neonates and older children, but the main thing to remember in neonates is workup is going to depend again on how the baby looks. If the baby is ill-appearing or the infant is ill-appearing, then something for us to think about is sepsis or torch infections, things like that, and we would pursue a urine and serum billy. If a neonate is well-appearing with just pale-colored stools, just an ultrasound might be sufficient. The differentials, again, broad in older kids, but things we could think about for them would be parasitic infection with CPV or EBV, or other things like reticular pathology, jaundice, or gallbladder disease. That's something to think about. So finally, I'm going to talk about just quickly the role of stool cultures, ova, and parasites. So basically, when do we get stool studies, and do we ever get stool studies? I know I've asked this question earlier on whether to get stool studies in children with diarrhea. However, according to the AAP, and a lot of times based on what we see, this is not really required, especially in acute cases of diarrhea, because most of the time it's self-limiting. So when do we get it? So any child with persistent diarrhea, where you're concerned for some kind of pathogen, any outbreak in a daycare or school or a hospital setting where you might want to identify this, or any kind of dysentery or bloody diarrhea where usually some kind of pathogen is more likely the cause, or a child who's immunosuppressed who's not going to clear this really on their own. That's when you would consider getting stool studies. Otherwise, you don't really need to go this route. So take-home points. So we covered a lot of topics about baby stool, so things that you should take home. Newborn stool commonly changes with consistency and frequency, and that's totally normal with age. With diarrhea, we don't often call it a cause, but find the cause, but the main thing is rehydration, rehydration. So doing a thorough physical exam and looking for any signs of symptoms of any underlying disease, that's going to guide our workup. Bloody stool can be a lot more than just infectious diarrhea. It can be things that are more serious like intussusception or makeup volvulus, and that's something to think about. And finally, antibiotics are really not needed for acute diarrheal episodes, and neither are stool studies. A lot of times it's just support. That was a lot about baby poop. Thank you, Dr. Keelan Feeks and Dr. Willis. Do you guys have any questions?